Thank you for joining us. We're giving people just a minute to sign on. We'll begin in a moment. Hey, welcome. Good afternoon to those on the East Coast. Good morning to other parts of the country. Thank you for joining us. My name is Rhea Farberman. I'm the Director of Strategic Communications and Policy Research at Trust for America's Health, also known as TFAH, TFAH. Trust for America's Health is a nonpartisan nonprofit organization. We're focused on public health research and policy. During today's briefing, you'll hear from 3 experts in the areas of public health policy, chronic disease prevention, and nutrition. We'll be discussing TIFA's new report, State of Obesity 2025, Better Policies for a Healthier America, which will be released tomorrow. We'll also have time for your questions. Following our panel, we should have about 25 minutes reserved for your questions. If you have a question, we welcome you to submit it at any time during the briefing using the Q&A tool. Please include your name and your outlet. Now, I'd like to introduce the first member of our panel, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She's a national leader in the area of health policy, public health, and health equity. During the Obama administration, Dr. Gracia was the Deputy Assistant Secretary for Minority Health and the Director of the Office of Minority Health at HHS. It's my pleasure to welcome Dr. Gracia. Please, the floor is yours.
Thank you, Rhea, and thank you to all of the media who are joining us today. Thank you for your interest in our State of Obesity report. And I certainly want to thank my co-panelists for also participating in this briefing and bringing their expertise to this discussion. And for over 20 years, Trust for America's Health has produced this annual report tracking the rates of Americans living with obesity. During that time, we've seen a steady increase in rates of obesity among U.S. adults and children across all population groups. Between 1999 and 2023, U.S. obesity rates have increased by 32% among adults and by 52% among children and adolescents. This year's report includes some positive news about obesity rates, but is also intended to call urgent attention to that fact that this progress is at risk due to federal funding cuts, staff layoffs, and eliminated programs. Next slide, please. Our report tracks U.S. obesity rates by state, region, race and ethnicity, age, and sex. It reports on evidence-based obesity prevention policies and programs. The report calls attention to the potential impacts of current and proposed federal funding and workforce cuts in chronic disease prevention and nutrition support programs, and it makes recommendations for increased investment in obesity prevention programs and policies. This year's report also includes a special feature on the emerging science and policy considerations concerning ultra-processed foods and their role in the nation's obesity crisis. Next slide, please. Now, here are some key findings in this year's report. There is a first-time improvement in the data, but as I noted earlier, this progress is at risk. Our analysis found that 19 states had adult obesity rates at or above 35% in 2024, and that's down from 23 states the prior year. That represents a first-time decrease in the number of states at or above the 35% level since this data set began in 2011. Next slide. Despite this one-year reduction in the number of states with adult obesity rates at or above 35%, which are shown in red here, the rate of adults nationwide who have obesity remains alarmingly high. Now, the positive step that's been demonstrated in the 2024 data, I will point out, is limited, as it's too soon to call it a trend. But this potential progress is also at risk due in part to recent and proposed federal actions to claw back and reduce funding for public health programs, eliminate programs and lay off experts that work on chronic disease prevention, and limit access to nutrition support programs. Simply put, for many years, the magnitude of the obesity crisis has not been matched by investment in proven obesity prevention programs. And now the significant reductions in federal funding and workforce move chronic disease prevention from a critical public health issue to an urgent risk. For example, the president's fiscal year 2026 budget request proposes the near total elimination of the National Center for Chronic Disease Prevention and Health Promotion at CDC, including the elimination of the Division of Nutrition, Physical Activity, and Obesity. This loss of funding and expertise translates to less work being done to research and implement best practices for preventing chronic disease and will lead to greater disease prevalence, burden, and costs. Given that an estimated 80% of CDC's domestic budget goes to states, localities, tribes, community-based organizations, healthcare systems, and academic and other partners to support programs and research, these cuts will hurt disease prevention efforts across the country. Now, when we look behind the data, what we know is that this is a population-level problem, and it really requires population-level solutions. Obesity is an important public health issue and a complex chronic disease that is influenced by numerous factors, many of which are beyond an individual's control. These factors include the economic and community context that shape Americans' daily life and their available choices around healthy food, physical activity, education, jobs, stress, and financial security, all of which systematically affect people's weight and health. For example, a family's ability to purchase healthy food may be limited due to their income. In addition, some neighborhoods have limited or no access to places to shop for fresh fruits and vegetables and limited public transportation. Likewise, some communities have limited or no access to safe places to be physically active, such as rec centers, walking paths, or parks. Now, while obesity rates have increased for many population groups with higher rates, including people who live in rural communities and some populations of color, typically face more structural barriers to healthy eating than people who are able to maintain a healthy weight. Some of these barriers include limited or lack of availability and access to affordable healthy food, having lower incomes, less access to high-quality healthcare, and limited opportunities to engage in physical activity. And these barriers play a role in population-specific obesity rates and disparities, for example, among certain populations of color and people who live in rural areas. So why does this matter? Well, TFAH focuses on obesity because it is associated with a range of physical and mental health conditions, higher mortality, higher healthcare costs, and productivity losses. Having obesity is associated with increased risk of type 2 diabetes, heart disease, stroke, and many cancers. Even our military readiness is affected as being overweight or having obesity is one of the most common reasons that young adults are ineligible for military service. There are also economic costs, where studies suggest that poor diet is responsible for over 500,000 deaths in the US and $1.1 trillion in healthcare spending and lost productivity costs annually. Our panelist, Dr. Susan Cansagra, is going to discuss some of the proven chronic disease prevention programs that are happening in states and those opportunities, and how greater investment in such programs could help address the epidemic of obesity. Next slide, please. In recent years, our annual State of Obesity report has included a special feature section, and that's to highlight a single critical issue within the broader subject area of obesity, chronic disease, and nutrition. Now, examples of some of our past special features include food and nutrition insecurity and the U.S. food environment and system. This year's report includes a special feature on the emerging science and policy considerations on ultra-processed foods, given the important new research and emerging scientific understanding of the health effects of ultra-processed foods and the heightened interest from researchers, advocates, policymakers, and the public on this topic. Americans are eating more food away from home, are not eating enough fruits and vegetables, and have high consumption of ultra-processed foods. Today, ultra-processed foods make up approximately 55% of calories consumed by Americans, and a growing body of evidence connects the consumption of ultra-processed foods with adverse health outcomes such as increased risk of obesity, type 2 diabetes, cardiovascular disease, cancer, and mortality. Next slide, please. We discussed several policy recommendations in the report's special feature on ultra-processed foods. For example, as efforts are underway to consider a definition, regulation, and possible policies around ultra-processed foods, consideration must be given to the risk of unintended consequences. There should be increased federal funding for nutrition research, and we should build on efforts to improve Americans' nutrition and maximize the consumption of healthy, unprocessed or minimally processed foods. Now, the role of ultra-processed foods in the nation's obesity crisis needs to be better understood. And at the same time, any policy actions on ultra-processed foods must not lead to or worsen unintended consequences, such as barriers to access and affordability of healthy nutrition, particularly for people who rely on nutrition support programs. Our next panelist, Megan Lott, will discuss the issue of ultra-processed foods in more depth. Next slide, please. The report also includes recommendations for policy actions that federal, state, and local policymakers and other stakeholders should take to help address the obesity crisis. Given the signs of progress, now is the time to retain and strengthen the National Center for Chronic Disease Prevention and Health Promotion at CDC, which supports proven disease prevention activities in states and communities. We also know ensuring access to healthy foods is essential to improving health. And we call on Congress to reverse cuts or propose cuts to nutrition support programs like the Supplemental Nutrition Assistance Program or the SNAP program, and the Special Supplemental Nutrition Program for Women, Infants, and Children, the WIC program. Next slide, please. The Food and Drug Administration should also implement a front-of-package nutrition label requirement to help consumers make informed choices. Congress should ensure access to health care, including obesity prevention and treatment options, by reversing cuts to Medicaid and extending marketplace subsidies. Grant-making agencies should address upstream drivers and root causes of health disparities and target obesity prevention programs to communities with the highest needs. And the report also shows how community design and where people live affect their access to safe physical activity. Therefore, we call on the Department of Transportation, Congress, and states to make physical activity more accessible by supporting active transportation and physical activity in communities. And finally, we recommend strategies to reduce advertising of unhealthy foods to children, such as by closing tax loopholes for such marketing. I thank you for your attention, and we're looking forward to answering your questions. I'll turn it back over now to Ria to introduce our next panelist. Thank you.
Thank you, Dr. Gracia. It's my pleasure to welcome our next panelist, Megan Lott. Megan is the Deputy Director for Healthy Eating Research at the Duke University Global Health Institute. She is a registered dietitian and earned a master's degree in public health from the University of North Carolina at Chapel Hill. Welcome, Megan, and the floor is yours. Yeah, I think we lost Megan's connection. So what we will do is go to Dr. Consagra next, and then Megan will come back on, and we'll go to Megan after Dr. Consagra. So let me introduce Dr. Susan Consagra. She is the Chief Medical Officer at the Association of State and Territorial Health Officials. She has directed chronic disease prevention programs for health departments in the city of New York and the state of North Carolina. Dr. Consagra, welcome, and the floor is yours.
Great. Well, thank you so much, Ria. Thank you, Dr. Garcia, and thank you to the entire Trust for America's Health team to bring attention to this really important topic. And, I wanted to say both as a prior state health official from North Carolina and also working in New York City, this is an issue that, all state and territorial and local health departments are continuing to look at to implement programs on the ground that support communities. And the issue really goes far beyond what any individual can do, though we certainly know there's opportunities there, but it's really about how we support healthy communities, how we support how neighborhoods are designed in a way that provides access to healthy foods and gives people the opportunity to move and live well in their communities. And so, you've heard a little bit of already this theme mentioned, and certainly is in the report as well. But I think the things that I want to highlight are, one, that it's not a unsolvable problem. We know there are solutions at work, and state and territorial health departments have been working on many of these solutions for many years, many decades, and we know it works. And so there's an opportunity to support prevention. It's also great to see that there is more national momentum and focus on chronic disease. We've certainly seen through Make America Healthy Again, this focus on chronic disease and lifting up this is a national focus. And there's an opportunity to take that interest and that focus and really gear that towards investments that we already know are based on things that work in communities, that are based on sound science, and based on the work that has already been laid on the ground by, again, many health departments across the country that are doing this. So investing in these is really important, especially again now as we see this renewed momentum. Health departments, oftentimes are the engine of change in their communities. They don't do that work alone. They work with many different partners to help ensure that there is access to healthy foods, that there are safe places to walk or bike or play, and working on making that design in a way that supports the individuals living in that community to make a healthy choice. So again, this opportunity and this point in time that we have, this national momentum, now is the time to help capitalize on that interest and really focus and double down on the investments that we know are necessary. People oftentimes, and certainly as a medical provider, we often talk about community versus what happens in the clinic. And, this is an issue that goes beyond clinic walls, as so many health issues are. It is something that we really need broad cross-sector work and partnerships to think about how we support making healthier choices easy for people, no matter where they live, whether that's a nutritious school meal, whether it's giving, play space on the weekends through joint use agreements with schools, whether it's designing communities in a way that have more accessible parks or more bike trails or complete streets that enable all of those things, walking, biking, as well as motorists. It's about supporting healthy access to foods, whether that's through government procurement of foods, whether it's in retail settings, through restaurants. There's many ways to do that. And again, a lot of work already laid on the ground to support some of these investments by health departments that have been doing this for quite some time. So, again, this is really the way that we transform entire systems around people to support that healthy choice. Another role is around connecting the data and what we see, the science of what works, and into solutions that can really work at the neighborhood level. And, I want to, again, just thank all the partners on the ground that make this happen, whether you work in a school, whether you work in a childcare center, whether you work in a church or a business. All of these sectors oftentimes come together to work with state and territorial health departments through that federal funding that comes in to support implementation of these programs, which is, again, why that funding is so important and why that funding really translates to community level action and change. There's specific programs, again, whether that's diabetes prevention, whether it's programs through Preventive Health and Health Services Block Grant, whether it's a program like WIC, a lot of evidence to support how these things help improve health outcomes, help ensure people have access to healthy foods, help support the very foundation, especially for our kids, support that foundation of health at a very young age that then demonstrates return for many years to come. Not only returns in terms of economic returns, but certainly the most importantly of health returns as well, laying that foundation for lifelong health. So overall, I just wanted to, again, emphasize this, national focus on thinking about systems, thinking about food systems, thinking about opportunities and how we design communities. It's such a momentous time to really double down on that, given some of the interests that we are seeing, given that this has been a focus of national conversation. And given that we do have investments in this space now, and now is a time to double down on those investments that come federally to states and local health departments, and to support that action within the very communities that are working to create those changes. So, taking that momentum and turning it into an action is, the work that we all would support. So overall, just want to, again, just thank those of you that are joining this call, focusing on this issue, and highlight again the really important and critical role of state and local health departments who have been doing this for a long time, who know what works, who have the relationships in their communities, have the partnerships. Supporting and funding them and their workforce is really critical as we move forward to continue to make a dent in this issue. So thank you so much, and I'll turn it back over to you, Ria.
Thank you, Dr. Consagra. Megan, welcome back. I'll introduce you, and we look forward to your comments. Megan is the Deputy Director for Healthy Eating Research at the Duke University Global Health Institute. She is a registered dietitian and holds a master's degree from the University of North Carolina, a master's degree in public health from the University of North Carolina at Chapel Hill. Thank you, Megan. The floor is yours.
Great. Thank you so much for having me today. Healthy Eating Research is a national research program based at Duke University. We've been funded by the Robert Wood Johnson Foundation since 2005. And since the program began, we have funded over 400 research studies centered on identifying the underlying causes of poor nutrition and obesity, food insecurity, and insufficient access to healthy and affordable foods, and determining the evidence-based policy, system, and environmental changes to improve health. Our research has informed the development and implementation of policies at the federal, state, and local levels. And our focus on policy systems and environments is important to highlight. As Dr. Garcia said, obesity is a systemic problem that requires population-level solutions. Part of this population-level approach includes shifting policies and systems to support healthier environments. This means we're thinking more holistically about the issues that impact a family's purchasing decisions. So knowledge about what to eat for optimal health is only a small part of the puzzle. We have to also think about issues like the price of healthy foods and beverages, the availability of healthy foods in communities, and taking an even further step back, the food supply. And this year's special feature section on ultra-processed foods is very timely given their recent prevalence in the media and policy decisions. In today's food supply, UPFs are the dominant source of harmful nutrient profiles. They're high in added sugars, unhealthy fats, and sodium, as well as additives associated with adverse health effects, including non-sugar sweeteners and synthetic colors. Extreme processing, preservatives, and packaging allows UPFs to flood the market. They are cheap, long-lasting, and always within arm's reach. And as Dr. Gracia noted, Americans are high consumers of UPFs, contributing as much as 55% to our total daily calories. They're a major driver of diet-related disease, contributing to obesity, diabetes, cardiovascular disease, and mental health conditions such as depression and anxiety. Recently, FDA, HHS, and USDA recognized the need to define ultra-processed foods for regulatory purposes with the hope of finding ways to decrease their consumption. Currently, the most widely used definition for ultra-processed foods is the NOVA classification system, which groups foods into 4 categories based on their level of processing. This framework was developed by a researcher in Brazil for the primary purpose of categorizing foods in research studies. So as a result, most of the data that we have available on the health harms associated with UPFs uses NOVA as the basis. And NOVA emphasizes that ultra-processed foods, or those falling into Category 4, are industrially processed foods, typically high in nutrients of concern and often intended to replace or displace fresh whole foods. While this approach has worked in research, it's not easy to implement in policies. NOVA does not take a product's nutrient profile into consideration. Thus, it wasn't designed to really distinguish those healthier Category 4 products like whole wheat bread, yogurt, and tofu from less healthy items like sugar-sweetened beverages, candy, and processed meats. Under NOVA, those are all considered ultra-processed foods. Also, because processing is not disclosed on food labels or packages, it can be difficult to identify products in a grocery store. Thus, you have seen some states default to flagging certain ingredients as markers of UPF in recent policy proposals. But evidence on whether this is a good approach is currently lacking. So while the evidence base is more than sufficient to warrant regulation of ultra-processed foods, the lingering question is, how do we do this in the best way? We want to identify the set of processed foods that scientific evidence shows are clearly linked to health concerns so that government policies can assist people in limiting those foods in their diets without having the unintended consequence of limiting access to healthy, convenient, affordable foods with no clear harms to health. One project in progress to address this is Healthy Eating Research has convened a national expert panel to develop an evidence-informed definition of ultra-processed foods that builds on the NOVA classification system, but will be useful for policymakers to consider as they aim to regulate ultra-processed foods with the goal of positively impacting nutrition and health. The expert panel is also considering feasibility of implementation in a variety of settings. For example, how you implement a policy in a school setting might be very different from in a grocery store or retail setting. So the expert panel is examining current research, nutrition guidelines, and UPF policies, and gathering input from experts in the field to understand research needs and policy opportunities. We're using the NOVA classification system as a starting point to consider a set of UPF definition alternatives that may use nutrient profiling, like limits on sodium, saturated fats, and added sugars, maybe a smaller set of UPF ingredient markers, or include product exemptions, for example, exempting those products meeting FDA's new definition of healthy. One of the exciting things, and the reason I'm sharing this with you, is because we are conducting new modeling analyses to assess the proportion of all packaged foods and beverages covered by each definition alternative and the proportion of UPF products captured. This will allow us to identify which options might be the most effective for policy regulation at capturing those harmful foods while not capturing those otherwise healthy foods that might fall into NOVA's Category 4 ultra-processed food definition. And we hope to have these recommendations published in early 2026. But in the meantime, another way to decrease consumption of ultra-processed foods is to increase access to and affordability of healthier foods, such as fruits and vegetables. And we already have important federal nutrition programs with these goals in place. Programs like WIC, school meals, and SNAP are designed to support a family's health and financial security, enhancing their ability to purchase healthy foods. The Special Supplemental Nutrition Program for Women, Infants, and Children, also known as WIC, has been around since 1974, serving women who are pregnant, postpartum, or lactating, infants, and young children up to age 5 who are at nutritional risk and living in or near poverty. WIC serves nearly half of all infants born in the United States. These services include providing nutritious foods to supplement participants' diets, as well as breastfeeding support and counseling, health screening, and nutrition education. The significant benefits of WIC have been well documented in the literature. Improvements in infant-child health outcomes, improved diet quality and diet-related outcomes, improved short-term cognitive development, increased access to healthcare, and increased rates of breastfeeding among WIC participants. WIC has also been shown to improve community food access. Where there's WIC authorized retailers, they're required to have these nutritious foods that are included in the WIC package always available, which then improves access to these healthy foods for everyone who lives in that community. School meals are another important program administered by USDA. They are a cornerstone of the nation's nutrition safety net for children for low-income families. 95% of U.S. public schools participate in the National School Meals programs, providing lunches to more than 31 million children on an average day. Research shows that receiving free or reduced price lunches reduces food insecurity, obesity rates, and poor health. In addition, the school meal nutrition standards, which were updated in 2012, have significantly improved the nutritional quality of meals served and the diet quality of participants. In fact, school meals are healthier than lunches packed from home. During COVID, USDA expanded access to free meals to all children nationwide. Since then, many states have adopted universal free meals due to the evidence documenting benefits to both students and schools, including improvements in students' academic performance and attendance, better diet quality, enhanced food security, benefits to obesity rates, and benefits to school finances. And finally, SNAP is the nation's largest food assistance program. Administered by USDA, SNAP provides nutrition assistance to low-income families meeting eligibility requirements via an electronic benefit transfer card that can be used to purchase groceries at authorized stores. Research has demonstrated that SNAP improves children's health and academic performance, lifts children and families out of poverty, boosts the economy, and helps stabilize economies. It's important to note that 1 in 5 U.S. children receive SNAP benefits. But in 99% of U.S. counties, SNAP benefits do not cover the cost of a modestly priced meal. The recent cuts to SNAP put the health and well-being of children, families, and communities at risk. Changes to program eligibility will have downstream impacts on school meals and WIC, as well as an already strained charitable food system across the country. We are all bracing to see food insecurity rates rise as a result of decreased investment and access to these programs. I know I'm at time. I look forward to answering your questions and to discussing more about how important these nutrition assistance programs are to the health and well-being of children and families across the country. Thank you.
Thank you, Megan. We now have time for questions. We have about a solid 25 minutes for questions. That's great. We can take questions at any time. Reporters, you can put questions in the Q&A tool, and please include your name and your outlet. So I'll begin with the first question. Is about Dr. Consagra, you referenced making sure that programs are science-based, but that work at the community level. Could you say more about that? What's the connection between making sure that programs are evidence-based, but will work in particular neighborhoods?
Yeah, I think a large role of public health departments is taking this idea of like science, taking vision, and really translating it into concrete changes at a community level in partnership with many partners. Communities know best what assets they have, what works for members, what is opportunity to create that multi-sector response that's often needed when we're working on these issues that are so large. And I think it goes back to like, how do we design systems in a way that work for individuals? And to do true systems change, you need to work on design and change at a community level that takes the input of the members that live there, of the partners that work there. I think about programs like, for example, joint use agreements. How do you create access to play spaces for children and opportunities for them to move more? Well, one way is to think about how you could partner with schools to leverage their facilities on a weekend or after hours. And that could be, an opportunity for collaboration to create that space. But communities know best because they know what assets are already in the community, where they have the ability to leverage these types of partnerships to create that systems change and design change that allows people to both access healthy foods and also move more to critical pieces of addressing the obesity epidemic.
Thank you. Dr. Grassi, anything else? Megan, anything on this issue? Okay. Next question is from AP. The reporter's looking at the number of states that did have a decrease in 2024, fewer states at the 35 or higher level, and asking about what influenced this reduction in the rate, and how significant is the reduction, given it is just 1 year's data. Dr. Grassi, can I ask you to begin, please?
Yes, and thank you for the question. It's important to note it because it is the first time that we are seeing that decrease in the number of states that have an adult obesity rate at or above 35% since this data set began in 2011. But as you noted, it is a 1 year depiction of this in 2024. What will be important is to actually determine if this is a trend is actually having the data in subsequent years and being able to then track and monitor. And that is critically what public health does. It is gathering the data, it's analyzing that data, and there's coordination between the local, state, local and state health departments and the federal agencies, in particular in this case CDC, that are then assessing that data to determine, is that a trend, and then research what might be the influencers that are contributing to this. It also means that with this type of a positive step or potential area of progress, it's why it's so important to continue to invest in the obesity prevention programs, the nutrition support programs, because we know that that progress can be at risk and can be very fragile in terms of seeing continued reductions in the number of states with this rate of obesity. And still and yet, the rate of obesity in the nation is still alarmingly high. So there is much more work that is still to be done.
Other thoughts on this question?
I would just second what Dr. Gracia said about recent cuts to federal nutrition assistance programs could undermine that progress. And so it's really important that we continue to have full program access, outreach, really enabling all who might be eligible and increasing that eligibility criteria to maximize enrollment in these programs so that families can continue to have access to the healthier foods needed to make these advances.
Megan, thanks for your presentation about ultra-processed foods. Obviously a complex topic, but what advice do you have for the consumer in the grocery store? What simple advice, if I'm not oversimplifying, what advice would you have that the layperson could act on today in terms of what they're purchasing in the grocery store and ultra-processed foods?
Yeah, as a registered dietitian, I get this question quite frequently, and I would say to my top recommendation is to always shop the perimeter of the grocery store. That's where you find fruits and vegetables, dairy, lower processed meats, the items that typically fit more within the recommendations of a healthy dietary pattern from the dietary guidelines for Americans. When looking at other products, it's important to just be knowledgeable and read those food labels, look for products that have fewer ingredients, but that is partly why coming up with this definition for policy regulation is so important, because it is very confusing to consumers when you go in the marketplace to identify what is a quote unquote healthier ultra processed foods versus those that might be harmful. And so where we know we have evidence that these ultra processed foods cause harm are around sugar sweetened beverages, candy, and processed meats. There are others, but those are the top three categories. So another piece of advice would say to really minimize or limit the purchase and consumption of those products in your grocery cart. Purchase fewer or no sugar sweetened beverages, less or no candy, and fewer processed meat products in particular.
Thank you. Our next question is about the waves of rifts that the federal agencies have experienced, including people working on national health data sets. What are the concerns about what will happen when we have less data and less access to health trends? Dr. Grassi, do you want to begin, please?
Well, data is critical to decision making. That is how having real-time and up-to-date data is how we can make really informed decisions, and that really encompasses the types of public health decisions that are made, as you heard Dr. Consagra describe, of what state and local health departments are doing, what other partners are doing, to be able to identify, for example, populations that might be disproportionately impacted, neighborhoods, communities that are disproportionately impacted by specific health issues, to be able to tailor resources, direct resources to communities that are in need, and then to be able to track progress or to see if efforts are not working, and then you're seeing that these issues are continuing to increase. And that is what we've been doing, for example, with regards to tracking the rates of obesity over these decades. That when we talk about these types of layoffs, that's expertise of staff who are collecting and analyzing these health statistics, that they're able to communicate this information to partners in states and local communities and other partners to be able to have really evidence-informed decision making. It means that, state and local health departments could lose access to health data and be able to not only see what's happening in their communities, but also be able to compare to other jurisdictions in their regions and be able to understand what types of programs may be most effective in addressing these types of health issues, including obesity, and also being able to develop the types of surveys and questionnaires that are going to be most impactful with regards to getting at the questions to be able to answer some of the questions we're seeing coming in from reporters about what may be contributing to these changes that we're seeing in terms of rates of obesity. I want to lift back up in terms of the data again with regards to what we saw regarding states and states, a reduction in the number of states that have adult obesity rates at or above 35%, that data is from 2024. And in addition to that state level data, we also have the national data, which also shows a small decrease in the rates of obesity among adults from the years of 2017 to 2020 to what the most recent data is 2021 to 2023. We saw a small decline from 41.9% to 40.3% in terms of the rates of obesity among adults. So that's the latest data that are available at the national level. And this is why it's so critical that we continue to have these data systems as well as the staff and the workforce to be able to track this information and then use that information to inform the types of public health decisions that are being made across the public health system to improve the health of communities.
Thank you, Dr. Gracia. Our next question is also from AP. It's about GLP-1s, the anti-obesity medications. And the question has to do with the role they may or may not be playing in stabilizing obesity rates. Dr. Consagra, can you begin, please?
Yeah, sure. I always think there's a role for both what we work on in a healthcare level and opportunities for treatment and support, and then what we work on in a public health level to support prevention that works together oftentimes when you see, changes in health outcomes and metrics. And, I think this is a great question and one that probably deserves further study, especially because there has been a lot of change in this space in the last several years, and one we should continue to look at, relying on those data systems that Dr. Garcia just mentioned as well. I don't know the hard and fast answer here, but I think it's an important question and one we can look at. And generally, I will say there's lots of things that have been also, in the clinical space as well, not just GLPs, but other types of interventions as well that have been a focus in a clinical and healthcare setting, especially as the awareness and knowledge about obesity grows among community and where they seek additional support from healthcare providers and what healthcare providers offer in this space. And at the same time, again, lots of emphasis on prevention efforts and likely both working in tandem to support changes. I think going back to the other question, I hope what we're seeing is not a one-time. I hope this trend continues. But the data, over the next few years will bear that out to be true or not.
Maria, if I could just add to Dr. Consagra's points, in speaking about the GLP-1s, which and obesity medications, just certainly being an important development with regards to the obesity management and treatment. And as she noted, the importance of really a comprehensive and holistic approach to addressing obesity, which is including obesity prevention and that investment in obesity prevention programs. Given the magnitude of obesity as a public health issue and knowing that we have programs that work to be able to address and prevent obesity, that investment is critical. And yet, for many years, we have not, as a nation, invested in obesity prevention programs to take them to scale that every state and every community that needs them actually benefits from those programs. That's what this investment can also bring when we talk about prevention, treatment, and management, is making sure that it's really a comprehensive approach towards addressing obesity as a public health issue and as the chronic disease that it is.
Dr. Garcia, your emphasis on investment is so well placed. It's a good segue to what's going to happen now, given the federal budget cuts that are happening, are proposed, the loss of expertise, the program closures. What's your concern about what happens to the nation's obesity rates as these cuts play out?
Well, I think it's important to take a step back and really understanding the importance of the federal funding, right? That federal funding is vital to the work that happens in states and communities across the country. For example, 80% of CDC's domestic budget goes to states and localities, to community-based organizations, to tribes and tribal organizations, to healthcare systems, to academic partners and other partners. And so when we talk about cuts to CDC funding, cuts to federal public health funding, that's cuts to state and local public health programs and efforts that are underway in those communities to be able to really promote and protect the health of residents and communities across the country. In addition to that, in addition to the funding, I should say, there's also the technical assistance that CDC and other federal agencies provide to states and localities. They're longstanding partnerships, again, to be able to share and learn from the research and share what are evidence-based programs and strategies towards addressing obesity and other chronic diseases. And so when you see that type of workforce reduction and layoffs, that means decreased capacity in terms of the workforce that is available, the experts that are available to work in partnership with states and localities to address such a longstanding public health issue. And what we may see as we go forward, if we continue to see these types of cuts and reductions, is we could see, for example, increases in our healthcare spending. We can see increased strain on the healthcare system because prevention programs are lost. That investment in prevention is lost, and the expertise that is there. We could see rising rates, as we've all been saying. We hope that these data that we're seeing from 2024 and the national data from 21 to 2023, that we hope that trend continues. But if we do not have these types of investments, the concern is that we will see these rates of obesity and other chronic conditions rise. And that could lead to, also even less healthy workforce and increased burden on workers and employers with absenteeism due to health conditions and decreased productivity. So there can be longer standing health and economic impacts that we could see for the nation if we see this continued reduction in funding and the workforce to address chronic disease.
And if I could just add, we're seeing already immediate impacts in terms of administrative burden on administering the federal nutrition programs, school meals, WIC, SNAP at the state and local level due to a lot of the reduced funding and reductions in force, which will have a very immediate impact of more families losing access to these vital programs, which the long-term consequence could be changes in obesity rates and health as well.
Yeah, I'll just double down on this point. They both said it so well, but, we hear everyday stories from our state and territorial health departments around the impact to funding reductions and the impact of funding cuts that have already happened and potentially proposed funding cuts, because living in a world of uncertainty is also hard to plan, to prepare, to start partnerships or create new investments on the ground when you don't know what is going to come after to sustain that, which is a big, piece of working with communities. You want to be able to support investment and to sustain it and to, live up to the commitments that have been made in supporting communities on a variety of health things. We're seeing, also, at the end of the day, public health has been chronically underfunded. There has been a patchwork of funding that supports public health infrastructure, supports public health staff. But the thing that health departments have been able to do is capitalize on partnerships in one area, whether that's a partnership around communicable disease, to then support a partnership that might focus on chronic disease. If you're working with a school on one thing and you've created that relationship, well, then you can, pivot and think about another health challenge. And so some of these funding cuts that have happened, even though, we will see what happens in the space around chronic disease, some of the things that we're already seeing around, prior rounds of funding cuts, or certainly the uncertainty in this environment, and certainly now even the pause around federal support in light of shutdown has a real impact on what state and local health departments can accomplish in their communities today.
And Rhea, I know we're all jumping in
You're fine.
a few times on this point. I think it's just such a critical one, and want to circle back to what Megan was describing around the federal nutrition assistance programs. And for example, I will share data that we are not seeing going in a positive direction was with regards to food insecurity. The latest data actually show that there was a rise in food insecurity in households, and this is exactly what these types of nutrition support programs are in place for. So many families and households that are just a paycheck away from really being in a situation that they are food insecure. And so seeing the types of cuts and reductions to SNAP and cost shifting to states where states have limited budgets, the concern that that many will actually either have less benefits or lose their eligibility at a time when we're seeing food insecurity continuing to be an important issue across the nation. This is why we need to not only assure that we're investing in prevention, but also assuring that we have that safety net as it relates to our nutrition support programs.
And Dr. Gracia, say just a word about the somewhat counterintuitive link between food insecurity and weight gain.
Yeah, so when you think about if a household, for example, really has uncertainty or has limited access to assuring that it has access to safe and healthy foods, what is often available, and Megan spoke about this in her presentation, is the less healthy option is often the one that is affordable. It's less nutritious, and yes, can be satiating, but is higher in calories, less nutritious, and therefore increases the risk for overweight and obesity and potentially other chronic conditions. So there is that paradox with regards to having food insecurity and yet being at risk for overweight and obesity. And the latest data that we have as it relates to food insecurity shows that it's about 13.5% of households. That's 18 million households that have food insecurity. That was a rise from the previous, a significant rise from the previous year. And so it's important that we have those types of nutrition support programs available. It's also important, going back to the data, that we have the data and surveillance systems to continue to monitor this. And unfortunately, that surveillance system on food insecurity was stopped, and we need to assure that we're able to continue to track that data again, so that we have an understanding of what the trends are, and to be able to tailor the investments, direct the resources where they're needed to assure that every family, every household has the opportunity to be healthy and to thrive and have access to healthy nutrition.
Thank you. We have time for one more question, and then we'll be going to the panelists for their wrap-up statements. The final question is about what the research says about the use of incentives or disincentives in the SNAP program, and what makes sense, what's advisable. Megan, can you get us started, please?
Yeah, this is another very timely topic. Since the beginning of 2025, 12 state waivers have been approved restricting purchases of unhealthy items like candy and soda with SNAP benefits as part of the administration's plan to test strategies to promote nutritious foods and limit what can be purchased with SNAP benefits. It's important to note that this is the first time a waiver has ever been approved by USDA to test these strategies. So there is evidence available, but most of that evidence looked at restrictions in a SNAP eligible similar population, but not using SNAP benefits, or they were modeling studies, because we haven't had a real world opportunity to test this approach before. So I will start by saying, at base level, more studies are needed to examine how these restrictions are going to be implemented and what effects they have. And it's really important that all 12 of these state waivers that are slated to go into effect beginning in January have really robust evaluation plans that allow us to see how they're working and what the consequences are. I will say, based on the research we have to date, we don't know that much about SNAP restrictions affecting participants' health. We conducted a review recently, actually, of published papers on this topic to look at, even, is there a difference between restrictions on purchases like this versus incentive approaches, like giving more money for fruits and vegetables, or a combined incentive disincentive approach. When presented with multiple SNAP policy options, it's no surprise that both SNAP participants and non-participants preferred offering incentives for healthier items like fruits and vegetables over policies that restricted their ability to purchase other items. Limiting sugary drinks, for example, was consistently the least popular option among both SNAP participants and non-participants. The research that we do have from these modeling studies shows that there are mixed results for impacts on food choices and diet quality. And some modeling studies suggest that both approaches, both the restrictions and the incentives, have the opportunity to improve health. But we do have a more robust data set right now on SNAP incentives showing that those are successful in promoting purchases of fruits and vegetables and other healthier items when included. So, to sum it up, that we need really robust evaluation of these 12 state plans moving forward, and hopefully we'll know more in a couple of years.
Thank you. Okay, we're now going to go to our wrap-up statements from each of the panelists. Dr. Consagra, we'll start with you, then we'll go to Dr. Gracia, and then to Megan.
Yeah, sure. Thanks, Ria. And, again, just want to emphasize how important this federal funding has been to state and local health departments that support work on systems change at a neighborhood and community level, that support active living, support healthy eating, and all the things that we know downstream will impact not only obesity rates, but other chronic diseases as well that we know are integrally, tied to obesity, and that are impacted by physical activity and nutrition as well. So, again, while we're seeing this change happen, this positive change, now is the time to double down on the investment that has already been made, not to pull away, because we know, again, we are starting to see this change. Health departments are the architects of their community, working closely with the broad sectors in a broad number of partners to make these changes a reality on the ground. And so let's capitalize on that momentum that we're seeing in this conversation around chronic disease nationally to really support what they do in communities with that federal funding, with that federal support, to make change that ultimately matters for the lives of people. Both health matters for long-term outcomes, matters for economic resilience of communities as well. So many gains in supporting healthy and resilient communities. So, again, thank you and appreciate the opportunity, and just can't emphasize enough how important that funding is and how that translates on the ground to individual people at the end of the day. So, want to, again, just emphasize that, but thank you.
Thank you. Dr. Gracia.
Yes, thank you. When we all speak about this, our goal is to have healthy individuals, families, and communities, and assure that everyone has the opportunity to be healthy as possible and to thrive. And, chronic diseases, inclusive of obesity, they are among the leading causes of illness, of disability, and death in our nation. And they also economically, along with mental health conditions, represent about 90% of our annual health care spending. But we have proven prevention programs that work. We have experts and an infrastructure in the public health system that can really tailor and address these needs for communities. And as Dr. Consagra said, now is the time for us to strengthen and increase that investment, increase it in chronic disease prevention, support and retain our infrastructure like the National Center for Chronic Disease Prevention and Health Promotion at the CDC, which has this as its primary function to be able to assure that we are utilizing evidence-based approaches and strategies to addressing obesity and other chronic diseases. This will help improve our health. It will also help to strengthen our economy. So now indeed is the time to invest. We will see that pay off in terms of our health, as well as helping to lower our costs as a nation. Thank you.
Thank you. And Megan.
Yes, I just want to reiterate what we talked about earlier in regards to the federal nutrition programs. These are some of the most effective tools we have to combat poverty and build stronger, more resilient communities. By providing families with the resources they need to afford nutritious food, these programs ensure that struggling households can get back on their feet, that they can continue to meet dietary recommendations and purchase healthier foods. The recent cuts to SNAP really jeopardize the health, education, and future of millions of children and families. And these cuts are going to have widespread effects on communities, deepening inequality, weakening the foundation of local economies. Um, if we had the opportunity to expand on recent improvements to SNAP we had seen in the prior years, rather than rolling them back, we would really help families thrive and I think continue to see these positive trends move forward. So I think that's my final thought is just really want to underscore the importance of these programs and supporting families and making this forward progress and just raising a flag to those cuts and potential consequences that are yet to come.
Thank you. Thank you to our panelists for your presentations and your insights, and thank you to the media who have joined us. We will be emailing the press kit and any resources mentioned during the briefing to you this afternoon. If you'd like to speak to any member of the panel one-on-one, please let us know. Please send an email with that request to TFAH, TFAH @burness.com. It's the same email you used to RSVP for today's session. And we will schedule something for you just as soon as we can. We understand you need to do that in a timely fashion. And finally, a reminder that everything discussed this afternoon and the materials shared is embargoed until 12:01 a.m. tomorrow, Thursday. Report releases overnight tonight, 12:01 a.m. tomorrow. Thank you for joining us and have a good rest of the day.